I think someone should start it now.
Dr. Sonali, please take over.
Yes. A very good evening to all. Welcome all, respected President Sir, Secretary Sir of MahaAP, respected judges, esteemed speakers and delegates to this program of Tuesday Takes in joint association of MahaAP and Women's Committee. Myself, Dr. Sonali Shirbhate, and my co-host, Dr. Sunita Ingre, welcome you all. We have respected judges and esteemed speakers from Pan Maharashtra, like Nashik, Bid, Sangli, Yavatmal, Nagpur, etc. They are selected zone-wise here in this program. The unique concept of Tuesday Takes of 5-minute short presentation with expert comment from our respected judges. And let me tell you all that all our speakers are masters in their own fields, and they had taken a lot of efforts since last 1 month for this program. So I welcome respected Dr. Gangolia sir, President MahaAP, respected Dr. Amol Pawar sir, Secretary MahaAP, respected judges Dr. Praveen Bhamri sir from Nashik, respected judge Dr. Satish Devpujari sir from Nagpur. I also welcome all 6 speakers from North Zone, Dr. Amol Murkute sir from Nashik, Marathwada Zone, Dr. Anurag Pangrikar from Bid, Western Zone, Dr. Bhavesh Shah from Sangli, Mumbai Konkan Zone, Dr. Abha Patankar from Raigad, and Dr. Amok Shahane from Navi Mumbai, and from Vidarbha Zone, Dr. Sachin Patil from Yavatmal. So, welcome you all. I would request our President MahaAP, Dr. Gangolia sir, to have an inaugural remark for this program.
Thank you, madam. Good evening, respected judges, respected speakers, office bearers of MahaAP Women Committee, as well as office bearers of MahaAP, to this second episode of Tuesday Takes. Hearty congratulations to this MahaAP Women Committee who has taken the initiative and make this Tuesday Takes program for all of us. At this age, being all, attention span being less, so 5 minutes concept, we have maximum attention span of 30 to 40 minutes. So within this 40 minutes, we are having 6 talks of 5 minutes each. So probably this session will help us in taking the take-home messages, which will be useful in our day-to-day practices. As well as probably take it in a lighter way, Dr. Anurag sir will have one more extra judge in form of me, I think so, because discharge card is very close to my heart. So probably one judge will be there for you. With this, I wish all the best, and I think so this session will be a very learning one. Wish each one happy learning. Thank you very much.
Thank you, sir. I request now our Secretary, Dr. Amol Pawar sir, for his inaugural address.
Good evening, respected Dr. Praveen Bhamri sir, Dr. Satish Devpujari sir, judges for today's session. Good evening, Dr. Hemant Gangolia sir. Then all the respected speakers and attendees on Zoom as well as YouTube. This is an innovative session. The idea came in mind of Dr. Renu Boralkar ma'am, who is the chairperson of Maharashtra IAP Women's Committee, and she told that why not we do such type of session. Then Gangulia sir and myself and the co-chairperson Sonali ma'am immediately agreed, and we then have started this journey. And zone wise we are taking 1 or 2. We are having 5 zones of Maharashtra, and then extra on rotation 2 speakers will be from one zone, and then other zones will have 1 speaker in each session. So monthly 3rd Tuesday we have selected, and this is second session. I give all the best to all the speakers And thank you one and all.
Thank you, sir. Now I request our respected judge, Dr. Praveen Bhamri, sir, for his takes for this program. Just inaugural few minutes.
Yeah, it's a very, very good initiative. In fact, I've already started enjoying the journey. Can you hear me now?
Yes, yes.
Yes, yes.
Can you hear me now?
Yes,
Yes.
sir.
Yeah, because yeah, you all are conducting it very well, and wish you all the best. And we hope more and more participants join and appreciate the whole affair. Thank you.
Thank you, sir. I would like to request respected judge, Dr. Satish Dev Pujari, sir, for his remark about this program. Sir, unmute yourself.
So friends, good evening. It's a nice and a wonderful idea, very practical, and something which can only come from young heart. So I can see so many youngsters here. Congrats. So please go ahead. Without any formalities, it's a wonderful idea. Congrats. Yeah.
Thank you, sir. Now I would like to hand on mic to our next moderator, Dr. Sunita Ingle, ma'am. Ma'am, please.
Thank you, Dr. Sonali. So it's my august duty to introduce our first judge, that is Dr. Praveen Bhamri, sir, from Nasik. Sir is a senior pediatrician, and he from Nasik, since practicing in Nasik since the past 34 years. He's an alumnus of Sion Hospital, Mumbai. And sir is going to give expert comments for the first 3 talks by the respective speakers. The first person coming up is from the North Zone, Dr. Amol Murkute, sir. And he's a pediatric intensivist from Safalya Hospital, Nasik. And sir's topic will be supportive care in PICU. Dr. Amol Murkute, sir.
Yes, ma'am. Yes,
you can start your screen sharing, sir.
Yes, ma'am. Is it visible?
Yes, but your audio is little hazy.
Yeah. Am I audible now?
Yes, yes.
Yes, sir. Go ahead, sir.
Yes, sir.
Yeah. Can we see the full screen?
Yes, we are seeing, but not full.
Pallavi ma'am, can you give me full screen? I just sharing my slides.
Okay, sir. I'm sharing slides from my side.
So good evening, all of you. At the outset, I would like to thank Maha IAP and Women's Committee of Maha IAP for giving me this opportunity. So you all must be wondering why this picture from Sholay at the beginning of presentation. One may infer, looking at picture, that supportive care is dying, which is sad at times, mainly in resource limited setting. But the point here I wanted to stress is that Amitabh Bachchan actually played the role of supporting actor in the movie Sholay, and he gave full justice to his character. And look how well it turned out to be. The movie was a blockbuster. Plus, movie मध्ये का होईना त्यांनी हिरोचे प्राण वाचवले. The supportive care in PSU is on the similar line. I would say supportive care in PSU is Amitabh Bachchan of Sholay. We should not let it die. The entities under supportive care should be well respected, honored, and awarded. Next slide. The entities which need to be awarded under the category of supportive care are to be remembered by a well-established mnemonic. The mnemonic is fast hugs in bed, please. Fast is for feeding, analgesia, sedation, thromboembolism prophylaxis. Hugs is for head and elevation, ulcer prophylaxis, glucose control, skin care. In stands for indwelling catheter care. Bed stands for bowel care, environmental adjustment, de-escalation of drugs. And last is psychosocial support. The idea is to practice or prescribe these fast hugs at least once in our PICU rounds at each patient's bedside. We'll see each entity one by one. Next slide, ma'am. So feeding on nutrition is one of the neglected part as far as PICU is concerned, unlike our NICU counterparts. The dictum is not to keep the kids fasting for more than 24 to 48 hours. And we should always make a habit to calculate the calories and proteins received in a particular day. Next slide. This first table shows the minimum amount of calories which are required to run the show, that is for BMR. And if you can observe, as the age advances, the calories required to run the BMR are decreasing with age. Having said that, in few conditions such as fever, trauma, burns, and sepsis, the calories required have to be increased by certain multiplication factors shown in table. On the contrary, sedated and paralyzed kids, they have decreased energy requirement, so we should avoid and try not to overfeed them. Next slide. Analgesia sedation is another one of the neglected part in pediatrics, and we can hear our kids begging like Sanjay Dutt from Vastav, kuch nahi to at least paracetamol hi de de. So for analgesia, we should think of giving at least paracetamol, and for sedation, we have a whole lot of options available. And research has proven that good analgesia sedation has better outcome as far as prognosis is concerned. Next slide. T stands for thromboembolism prophylaxis, which is not routinely practiced or recommended in pediatrics. However, surviving sepsis guidelines recommend its use in post-pubertal children with severe sepsis. Next. This completes fast. We all move out to hugs. H is for head end elevation, and we all know the benefit of head end elevation. But having said that, we should also remember we should not elevate head during CPR and in hypotensive shock. Ulcer prophylaxis is recommended in certain conditions with risk factors, with ranitidine or PPI. But in our IPDs, pantoprazole or ranitidine has become as ubiquitous as ceftriaxone in our hospitals. So in that head, we are way ahead. Next. Next slide, ma'am. Yes. Glucose control, tight glycemic control is not recommended in pediatrics, unlike adults. But we all strive very hard to prevent hypoglycemia. But seldom do we address the hyperglycemia, which is equally detrimental to sick kids. The recommendations say that if the levels are consistently above 180, we should consider insulin infusion if the sugars are not responding to reduction in GIR. Next. S stands for skin care, but it is usually they usually mean to address pressure sores in sick patients, which is commonly seen in hypotensive kids and those who are on HFOV and with prolonged hospital stay. Plus eye care with lubricating eye drops and oral care with chlorhexidine, especially in intubated kid, is equally important. Next. Next slide. For pressure sores, there is this staging available. And the stage 1 is non-blanchable redness. Stage 2 has ulcer. Stage 3 has a visible subcutaneous fat. Stage 4 has exposed muscle and bone. The treatment for these pressure sores ranges from protective dressing, saline wash, up to debridement. Next. For in is for indwelling catheter care, and we all know how to monitor ET, CVP lines, and chest drains. Next. But the thing which we neglect, next ma'am, the thing which we neglect are IV cannulae and the thrombophlebitis arising from it. This is a simple VIP score which stands for Visual Infusion Phlebitis Score. I would request all of you to take a printout of this, which is readily available on internet, give it to your sisters, and they should plot this VIP score at least once in their shift duties on a case paper, so as to pick up early phlebitis cases and prevent the complication arising from thrombophlebitis. Next. B stands for bowel movement, which we should ask during PICU rounds. Environment stands for environmental adjustment or anything which can lead to discomfort in a child should be addressed. Next. D is for de-escalation of drugs, which is usually meant for antibiotics. And during our rounds, we should always ask ourselves which of the drugs which the child is receiving can I reduce. Next. Last but not the least is psychosocial support. The dictum is to counsel, counsel, and counsel, followed by documentation, documentation, and documentation. Next. So in short, there are these 13 entities under supportive care. Fast hugs in bed, please. which are very easy to remember. And I would request all of you to practice these fast hugs at least once during our PICU rounds so as to get a good outcome in these sick kids. Thank you.
Thank you, Dr. Amol. That was super fast presentation, and that fast hugs in bed, please, was a wonderful mnemonic. Let us listen from the judge, Dr. Praveen Bhamri, sir, what he has to say about it. Over to you, sir.
Yeah, Amol, a very good presentation. I was happy that you could include almost everything that you needed in supportive care.
Thank you,
in
sir.
just 5 to 6 minutes. Would you want to just run those slides so that when I ask you a question, the relevant slide should be in front of us?
Yes, sir.
Fast, put the slideshow back again.
Yes, sir.
Yeah, go on. Go on slide 5 straight away.
Yes, sir.
Yeah, next. Okay, on analgesia and sedation. Yeah.
Yes, sir.
Now, what I wanted to ask you was, how would you know that the child is experiencing pain in the PICU? You said that you got to take care of the pain and sedation.
Correct, sir. Sir, for pain, there are a variety of scales available. The pain faces or the Baker faces, which can easily tell you the pain score. Apart from that, there is another scale called as FLAC scale, which stands for, F stands for face, L stands for legs, A for activity, and double C for cry and consolability. There are the criteria under each heading. We give a score, and the FLAC score is advised up to 7 years of age. But in intubated kids with lot of tapes around the face, it is difficult to identify these faces. So what I would, the practical approach is to see the agitated child with unexplained tachycardia would be a better thing to know if the child is in pain or not.
Yeah, that's a good one. But then, like to be a little more practical, just tachycardia, tachypnea, falling oxygen saturation, pupillary dilatation, the child becoming hypertonic, sweating, all these things also will tell you that the child is in pain, rather than going in for those scales, which may remember, we may not remember. Next slide. Your next slide is on thromboembolism.
Yes, sir.
Okay, why and how will you assess the patient for thromboembolic phenomena? Please be brief, okay? Because we can ask you more questions. If you just answer in 1 or 2 sentences. So why do you need thromboembolism?
So thromboembolism is a life-threatening scenario, and in today's era, we are identifying more and more kids with risk factors for thromboembolism, for malignancy, chronic cardiac renal diseases, and the kids are with CVP lines. So it is very important to identify thromboembolism in a child. And second question was how to assess her, right? Assessment can be clinically, which can actually identification clinically is little difficult because the diagnosis is usually by exclusion. But certain clues such as hypoxia, desaturation, cough, hemoptysis, or chest pain can give you a clue to pulmonary thromboembolism. Sir. Apart from that, investigations such as D-dimer and USG, 2D echo can give you a clue towards thromboembolism, or with this Doppler study, sir.
Yeah, basically what I wanted you to even include was, like the chance of pulmonary embolism and deep vein thrombosis. And you can assess the deep vein thrombosis also in the legs or something by just pain, swelling, skin temperature which goes cold and clammy, and engorged veins. You can do a Homans test also if you can. And this is good. We go to the next slide. And the next slide is on head end elevation. How does the head end elevation really help in the PICU? Just in one line.
Sir, head end elevation prevents the microaspiration, and in ICP, it causes more jugular venous drainage. In both ways, it helps. And for ICP, the recommended head end elevation is 15 to 30 degree, not more than 30, because that may compromise the cerebral perfusion pressure.
Yeah, so it should be minimum 30, not less than 30, not preferably more than 30. 30 to 40 is good enough.
Yes.
But the main thing I wanted you to tell me was that, actually it does not decrease the chance of aspiration. It increases the chance of aspiration. Whenever you want to decrease the chance of aspiration, you put it in the head low position. But it increases the tidal volume. And so more so if the patient is in a prone position. Now, this is a similar thing as you see for adults in COVID patients.
Correct,
Right.
sir.
The next question
Yes.
is basically on glucose control. What causes hyperglycemia?
So the
What
most
causes
commonly which,
hyperglycemia?
yes, sir, most commonly which we see in PICU is stress and the release of hyperglycemic hormones, which leads to hyperglycemia in PICU. Another which is commonly and practical thing is the extra IV fluids with dextrose containing fluids can give rise to hyperglycemia. Apart from that, sepsis itself can cause hyperglycemia.
Yeah. So basically, it is that the stress-related factors increases the inherent corticosteroids, and
Yes, sir.
those in turn increase the glucose levels,
Correct,
and
sir.
that is how you see it. And the stress hyperglycemia is more difficult to control even than the diabetic hyperglycemia.
Yes,
The
sir.
next question, the next one is on skincare. I want to really appreciate that you included this part because we as pediatricians always forget to take care of the skin. The next slide was on indwelling catheters. How and how often would you check for displacement of a CVP line? How would
It
you check the
is,
displacement of a CVP line?
yeah, actually, it is rare for CVP lines to get displaced because they are well suited. And the usual formula is to see for the backflow and the obstruction to the flow. Apart from that, extravasation of drugs can give you a clue, but I won't wait till the drugs get extravasated, sir.
Yeah, and in case it comes to extremes, you can do a sonography and see where's the tip of the catheter.
Yes, correct.
De-escalation of drugs, could you tell me which are the antibiotics you would prefer to de-escalate and how fast would you want to do it?
So the de-escalation of antibiotics it is usually, I would ask myself, am I treating infection or not? If the answer is yes, I'll ask another question if it is bacterial or not. Then I would try to make precise diagnosis as early as possible. That will give me some timeline as to how fast or how slow should I de-escalate. And the next one would be the site of infection, the source of infection, whether hospital acquired or community acquired, the local epidemiology of the disease, and the drug profile. For example, if I'm treating a gram-negative sepsis, the linospan doesn't or the linezolid doesn't hold anything. And if I am treating a community-acquired pneumonia, ceftriaxone is more than enough for a particular child. So if I ask myself these 5-6 questions, I'll be able to de-escalate as early as possible, sir. Plus, if we get the culture sensitivity report in hand as early as possible, the de-escalation would be really easy and fast.
Yeah, that answers my questions completely. I just want to make a comment, in the last one, that psychosocial support. I'd rather talk to the parents on daily rounds, show them the monitors, however little they can comprehend, or even the reports for that matter, and explain them the change from yesterday to today. Thank you, Amol, for the wonderful presentation. We can go to the next presentation.
Thank you, sir.
Thank you so much, sir, Dr. Amol and Dr. Bambri, sir, for giving such practical inputs. Now we move to the next topic, and it is the most common document which we write is a discharge card, and presenting it is Dr. Anurag Pangrikar from Marathwada zone. Actually, he's from Beed. Sir is a gold medalist in MD and also holds a law degree. He's a practicing pediatrician at Beed, and he's also president IMA Beed, and he's the organizing chairperson of 2014. Over to Dr. Pangrikar, sir. You can start sharing your screen.
Thank you. Just a minute. So, it was nice presentation. In the PICU, child was managed well. But the most important is documentation of how you manage the child in PICU. Here comes the role of discharge card. And I will be brief for 5 minutes. Thank you all the concerns. Discharge card is the only document that goes out of your hospital. And that is so, it is called as the mirror of care given by you. When a patient is admitted in your hospital, there are 3 ways. Either you treat him, cure him, or and discharge him. So you need to hand over the patient discharge summary. Secondly, If you are referring this patient to another hospital, you need to give discharge notes. Unfortunately, if patient is of natural cause, you need to give death summary. So every patient going out of your hospital has to have some paper, what treatment he has received. All these records should be given to all the patients without any charge. No fees can be charged for giving discharge card, including those patients who live against medical advice. If the patient has not paid medical bill or your hospital bill, still you need to give these three things to patient. Thus, these documents are legal. You cannot refuse them. So what is discharge card? A part of patient record that summarizes reasons of admission, clinical findings at the during hospital stay, and what was the progress, procedures performed, treatment rendered, how was patient at the time of discharge, and specific instructions to relatives and patients, including medicines. Whenever the patient is admitted with you, you have to plan the discharge. Suddenly you go to ward and say, this patient is discharged. You need to plan it. You need to discuss it with patient and family. And the treating doctor, it is his duty to see that everything is documented in the discharge card and he has to sign it. An unsigned medical record has no legal validity. So at many places, junior resident or somebody else writes the discharge card, and which is written in very poor manner. We should stop this thing. So the discharge summary contains basic data, unique identification number if we are giving some number to every admission, name of treating doctor, date and time of admission and discharge. So this time factor is important, especially in patients who are very critical and who are discharged in bad condition, who are referred to higher center. Time must be placed. In case of death, the summary of case also includes cause of death. In reasons of admission, we always write with what chief complaints patient was admitted, what are the initial examination findings, and what are probable diagnosis. If you have some differential diagnosis, you can put them on initial part of discharge card. Then, how was the progress of the child in hospital? So procedures and treatment provided in the hospital, like which medications were given, the dose, route, and duration. Few people write appropriate medicines in appropriate dosage were given. So this is wrong. Any new complaints added during hospital stay, deterioration, complication, any adverse event you noticed. Consults. If you have consulted other doctors, specialists, you must write that. Procedure findings, surgical findings, test result, and if you have noted any allergy during the hospital stay, you must write it. And how was patient at the time of discharge? What was your diagnosis at discharge? Whether patient has cured, improved, deteriorated, or died. And whether you have discharged the patient to home or other hospital, that has to be mentioned on discharge card. And at the last, you should give the patient and family instructions, like which medications to continue, for how much duration, in what dose. When follow-up is needed, what are dietary needs, any follow-up tests or procedures you have advised. In case after discharge, the child has any emergency, where he should consult. How is the lifestyle recommended after this discharge? Everything should be there. There are few case laws in which preterm baby who was discharged was not advised ROP screen. And that's why these doctors had to pay compensation. In the last, attending physician's signature and date should be placed. The most important thing in medico-legal aspect is you should have copy of your discharge card. And it is better that you get sign of relatives on the discharge card that we have received discharge card and we have understood the instructions given by doctor. Because in one medical legal case where premature baby was discharged, relatives, it was advised on discharge card that is do ROP screening in this hospital on that day. But relatives said that we have not received discharge card, so these instructions were not given to me. So such false claims can be there. So please keep a copy of your discharge card, get signature of relatives on the discharge card. This is one pro forma, including all the discussions we had done in the last 5 minutes. I'm sorry for 6 minutes, 15 seconds, exceeding 1 minute, 15 seconds. Thank you.
Thank you so much, sir. It was wonderful discussion on discharge card because we write it very often. There is one question in the chat box that we don't write reports in detail. Is it okay? And I will ask Dr. Praveen Bhamri, sir, to come in and give his expert comment also. So you can answer this question.
Yeah, basically, first of all, I'm very happy you've done a very good job, Anurag, and that shows your experience in an online presentations. You've done a very good job. You were very lucid and very clear about matters.
Thank you, sir.
I had a slightly different look on this. If you all permit me, in just a minute or a minute and a half, I'll tell you. I would have seen the discharge card written in the, right from the time we see the patient. What was the presenting signs and symptoms of the patient? That means what were the clinical findings on admission and on discharge? That means on admission, there was one thing, and on discharge, whether those things have gone or not. Course of illness, whether there were any unusual happenings or findings during the stay, example, aspiration or oliguria, and how did you handle them? Then we come to the diagnosis. What was the initial diagnosis on admission, and what was the final diagnosis on discharge? That means each and everything, the way the child first came to you and when the child left, you should know the presenting signs, symptoms, the course of illness, as well as the diagnosis. What if the diagnosis was not reached by discharge? Now, that is another important thing, because sometimes we put the diagnosis like PO. Now, then both the reasons and the efforts need to be explained. Especially fever was present for, say, 7 days before admissions and even 3 days after admission. Now, piece of advice is do not suppress fever just to assuage the parents by giving strong anti-inflammatory treatment or steroids, etc., because fever will recur after discharge and you'll get the blame. Instead, explain to the parents, example in a connective tissue disorder, that fever is bound to recur, but do not panic, because I have done enough to see to it that the child does not deteriorate. Or in a UTI, you can't keep the patient in the hospital till the last pus cell has left the urine. So fever might still come. Then you got to, I think one thing you overlooked was the opinions and inputs during hospital stay of other faculty, like a surgeon or a neurologist, etc. Instructions for follow-up tests like a repeat USG, echo, biochemistry for looking at remission, reappearance, or the exacerbation of disease. So these points need to be added so that, we are clear as to all these things. Whenever if I see a patient even discharged by someone else, I know what has happened visually over there during this day. Thank you very much. A good presentation. We can go to the next presentation.
If moderator permits, can I ask 1 or 2 questions?
Sure, sir. But keep it short.
Dr. Anurag, sir, first of all, very good presentation.
Thank
2
you.
questions which are coming to my mind. You have said in one of the slides that one has to keep the copy of the discharge card. So how many years one is to keep the discharge card? 1. And if they want to destroy, how is to be destroyed? And the other questions, after you answer this, I will ask another question.
First thing, according to MCI code, you have to preserve all the documents till 3 years. For pediatric patients, it is mentioned that 3 years after the child attains majority, that is age of 18 years. So until child attains 21 years, you have to preserve these records. If it is medico-legal, there are you feel that there is some foul play, some medico-legal part is there, something is fishy, better preserve it lifelong. For destroy, when you want to destroy, you have to give notification in a regional and local paper that I am destroying documents in my hospitals up to this date. If anybody wants copy of it, please approach within these much days. That is the way you have to preserve and destroy. If any expert comment from you can be added.
No, that's right. So it is only one rule is existing, that is 3 years only. And after 3 years, one can destroy. The question of 21 years is coming, that is our, because the period of limitation getting the minor and the majority major, that is the reason. but it's very difficult to keep all the records. At least what the cases where the medical legal issues or the complications, or you anticipate the things which can go wrong, has to be resolved almost say to lifelong. The second thing is that if the patient after the discharge comes and says, I have lost the discharge card and I want this copy from that, so how will you give, or will you refuse, or how to go about it?
Okay, if patient wants copy of discharge card, he's saying that I have lost it, it can be given. But if any dues are pending, hospital bill is pending, that time you can ask for it.
So yes, so they can demand again. We have to keep that copy, but then we have that 72 hours to take the time to give the. It's not immediately one has to give. So
Yes,
we
yes.
have the 72. Thank you very much, Dr.
Better get written letter from them,
Yes,
that I want this discharge, identity of the patient, whether he is really the relative of the patient, and then issue the discharge card within 72 hours.
Yes, an application has to be addressed to the hospital, then has to be issued.
Yes,
fine.
Thank you. Thank you.
So there was one that should we write reports in details? Is it okay or no? That was
Yes,
the question.
sir, you want to say whether we should write all reports in detail? That is the question chat box.
Yes or no, sir?
Yes, we should write. At least specific things must be mentioned.
Yes,
at least.
I agree.
Okay, thank you so much, sir. Now we proceed to the next speaker, who's from Western Zone, and he's Dr. Bhavesh Shah from Sangli. He's Associate Professor, Department of Pediatrics, GMC Meerut, and he's a coordinator of IAP Accredited CPR Training Center, Senior Instructor, ALS, BLS, NRP, West Zone. And sir is going to speak on quick recognition of sick child. Dr. Bhavesh Shah, please, can start your speech.
Yeah, good evening. Can I share?
Yes, sir. Yes, sir.
Yes.
Is it visible?
No, sir. Okay.
Click the PPT down. Yes, PPT. Yes, PPT.
I guess now it's visible.
Yes, yes,
sir.
yes.
And I'm audible enough?
Yes, sir.
Yeah.
Go ahead.
Yes,
So-
audible.
Yeah. Thank you so much, MahaAP and all the administrators who allowed me to present a very small topic. And it's a recognition of sick child. As we know that in OPD practice as well as in casualty whenever we are there, and the most important thing what we need to separate is a sick child from a routine child. It is very important to know the sick child. The reason is very important. Once you evaluate and identify a sick child, we don't keep on evaluating the child, but we start intervening the child. And after intervention, again, you evaluate. It's very important to intervene after finding the child is sick. So what do you mean by sick child? The most important thing to find in a sick child, the first thing is whether the child is in cardiorespiratory arrest. If fortunately this child is not in cardiorespiratory arrest, the next imminent thing what we want to find out, whether this child is in respiratory failure or hypotensive shock. And if fortunately enough, this child is not even in respiratory failure or hypotensive shock, we need to find whether this child is in respiratory distress or compensated shock. These are very, very important diagnoses which we need to make, and all these 5 comprises called as a sick child. Because every point of this, for example, right from compensated shock to cardiorespiratory arrest, we need to act. At any moment there is a life-threatening problem, a life-saving intervention has to be done. So let us go and find how will you do that. So how we do this is, first thing is something called as pediatric assessment triangle. The first step in recognizing a sick child is once the child walks or it is brought by a relative into the OPD or a casualty emergency, we need to do some initial impression, which is nothing but a very quick, in seconds, a visual and auditory assessment of the child's three important systems: a neurological, a respiratory, and a circulatory. What we want to find in neurological system, whether this child is having a proper responding to our stimulus or not. While in breathing, we try to find what is the work of breathing like in a child, and in circulation, we want to know whether the child color of the skin looking pale, cyanosed, or whether it is a mottled. What we want to diagnose by knowing all these three things, A, B, and C, called as pediatric assessment triangle, is something in appearance, a neurological status of the child, whether the child is responsive or unresponsive. In work of breathing, whether the child is having gasping breathing or isn't there any breathing, that is no breathing. And in circulation, whether child is having cyanosis. These are the three important signs, which is very visually and auditory quick assessment can pick up. Diagnosis, cardiac arrest or cardiorespiratory arrest. In this case, we don't go for a primary evaluation or further evaluation. We need to act there and that, called as BLS or basic life support, cardiopulmonary resuscitation at that moment. We don't go further. But fortunately, if it is the child is not having these signs, then we go for further examination or evaluation, that is called as primary assessment. It has 5-prong approach. It's a classical hands-on ABCDE approach, where we touch the patient, we examine the patient, and we also use kind of monitoring systems like pulse oximeter. So what are those 5 points? Again, these are called as A, B, C, D, and E. A is to know the airway of the child, whether this airway is clear or whether it is obstructed. Then we know the breathing part of the child, where we know the respiratory rate, the respiratory effort, chest wall expansion, lung and airway sounds, and pulse oximetry. While in circulation, we come to know that heart rate and rhythm of a child, peripheral and central pulses, a capillary refilling time, which is very important clinical sign, and skin color and temperature, and also the blood pressure. These three are the most important, but not without knowing the disability of the child by knowing the AVPU scale and the exposure, that is the skin of the child, knowing about the temperature and any other deformities lying. So what we exactly want to find out by doing this 5-prong approach of hands-on ABCDE. In airway, we want to know whether this child is having a complete or severe airway obstruction, then it is a life-threatening condition. Whether in breathing the child is having apnea or bradypnea, similarly a significant work of breathing is there, severe respiratory distress, this child is in significant need of intervention rather than further examination. In circulation, any child who presents with bradycardia, no detectable peripheral pulses, prolonged capillary refilling time, or present with hypotension, this child again requires immediate intervention and not the further examination and transfer and all that. While in disability, whether the child again is unresponsive or severely depressed. While in exposure, we want to know whether this child is in hypothermia. So these are the 5 important things we want to know after the primary assessment. If anything out of this is there, this child requires immediate intervention and then further assessment. So suppose fortunately child does not have this life-threatening condition, then we go further and try to diagnose whether the problem in the child is respiratory insufficiency. If it is there, then identify the severity. This severity can be a respiratory failure or respiratory distress. Similarly, if there is no respiratory insufficiency, whether there is a circulatory insufficiency. If there is a circulatory insufficiency, we want to know whether this child is having that insufficiency in the form of hypotensive shock or compensated shock. So let us know what is difference between respiratory failure versus respiratory distress. And this is clinical. So if you can see here, any child who presents with respiratory symptoms or signs like tachypnea, increased respiratory effort, abnormal airway sounds, and irritability is maybe in a respiratory distress. But at the same time, along with these symptoms, if the child, which is in asterisk mode, you can see it's presenting these signs with stuporous or comatose condition and presence of cyanosis, this child is in respiratory failure. Our friends, I just want to stress here, respiratory failure is a condition where we need to act so fast because cardiorespiratory arrest is very imminent in few seconds. While respiratory distress, we need to act supportive measures so that child should not land up into respiratory failure. The second point, if the child is not having respiratory insufficiency, does the child have cardiac insufficiency? In that case, again we go try to find, once we check the 5-point checkup with ABCDE, or especially the circulation, we know if the child is having tachycardia, cool skin, delayed capillary refilling time, very weak peripheral pulses, and oliguria, this child is in compensated shock. Friends, here compensated shock means if blood pressure is normal or narrow pulse pressure, but everything else is compensated. But here in hypotensive shock means the child has already compensated enough and now getting decompensated, presenting as a hypotension. And hence this child again is in imminent stage, immediately within seconds or minutes is going to land up into cardiac arrest. So we should differentiate between compensated shock and hypotensive shock so that our actions begins immediately. So the last summary slide is, first we do the initial impression, very quick visual and auditory without touching to know whether this child is in cardiac arrest. If it is there, start intervention. If it is not, then we try to find whether there is a problem respiratory. If the respiratory insufficiency is a problem, we try to diagnose whether it is respiratory failure or respiratory distress. And if it is circulatory insufficiency, we want to diagnose whether it is hypotensive shock or compensated shock. The last thing, the patient does not present only with respiratory or circulatory, it can be mixed also. So if we go with this protocol, probably we will never miss a sick child where the action is more importantly required than anything else. Thanks.
Wonderful presentation, sir. Very lucid approach for a quick recognition of a sick child. I'll request Dr. Praveen Bhamri, sir, to please come in and give his expert comments.
Yeah, Bhavesh, you did a real good job. You really did very well. I'm happy about that. Now, I think, we are already crossing time, so I will skip a few questions. I'll just reiterate that when you said about evaluate, identify, and intervene, that means that if you find a life-threatening condition, even if you find something in the airway, and if the airway, you see that the child is going down, before going to the breathing and circulation part or whatever it is, you first handle that. So the evaluate, identify, and intervene means that as and when you spot a problem, you act on it immediately. I will skip the other questions so that the remaining speakers also get a good time. Thank you very much.
Yeah.
Thank you.
Thank you, sir.
Thank you so much, sir. Thank you, Dr. Bhavesh and for Dr. Praveen Bhamri, sir, for giving his expert comments. Now I will hand over the proceedings to Dr. Sonali Shivratri. Madam, over to you.
Yes. Thank you, madam. So I would like to introduce our second judge, respected Dr. Satish Devpujari, sir. He is from Nagpur. He is director of Sri Child Clinic, Nagpur. He is professor emeritus IGMC, Nagpur. He is adjunct professor VNZT, Nagpur. He is director Center of Excellence of DM IMS, Nagpur. He is chairman in PICC chapter from 98 to 2000. Actually, sir's CV is very vast, but I had made it short for the time being. So I welcome Dr. Satish Devpujari, sir. So our next speaker, I call upon Dr. Abha Patankar, sir, from Raigad. He is practicing pediatrician since 24 years in Raigad. His special interest is in intensive care and neonatology. So over to you, sir.
Thank you, Sonali, madam.
Is IGRA, interferon gamma release assay.
Thank you, Sonali, madam. May I share the screen now?
Yes, yes.
Yeah. Thank you for kind introduction. And I am really happy that my mentor is Dr. Satish Devpujari, sir. It is like my dream is coming true. I'll try to justify my presentation. At the outset, let me thank Maha IAP and Women's Committee for giving this opportunity on Tuesday Talks. My topic is IGRA. As a generalist, I would like to know what are IGRAs, what are advantages and disadvantages of them, what is sensitivity and specificity, how do I order the test, and what I will do if the test results comes positive or negative. How does it is going to change my clinical practice? What are the recent advances and way forward? Let me honestly tell you that I'm not an expert in the subject. At the same time, I'm learning in the process. IGRA is interferon gamma release assay. It is just to identify TB infection. It cannot differentiate between TB infection or TB disease. It is in vitro test. As we do TST, which is in vivo test, it is of the same value as TST, but with some advantages, like it is not affected by BCG status and it has excellent negative predictive value. But there are a few shortcomings, like it is not validated for less than 2 years, where TST proves to be better. TST and IGRA are indirect tests and they depend upon the competency of the immune system, because we measure immune responses to TB antigens. There are of two types. One is quantiferon, another is T-spot. Positive results in either test is not an indication to progress active disease. So what exactly these IGRA do? These IGRA do counting of interferon gamma, which is released by these infected WBCs or sensitized WBCs. They are measured in two forms. In one form, it is measured as a whole blood. So when it is measured as a whole blood, it is called as quantiferon. And when it is measured as a number of lymphocytes, it is called as TB spot. This is the major difference of the two tests which are under IGRAs. It requires fresh blood samples, and depending upon the test, the antigen testing method, the interpretation differs. The results may come as positive, negative, indeterminate, or borderline. Here the figures which I have quoted, they are from many references. One may not agree with it, but what is there is a QFT-GIT which is available. This available to us at present, which has got 97.9% sensitivity, and specificity of these IGRAs is around more than 95%. When we compare with TST, you can see the sensitivity is definitely lesser than this quantiferon IGRA test, while specificity is definitely lagging away below. These tests, IGRAs and TSTs, as I have already mentioned, they perform very well when the immune system is quite good. So they are not good in malnourished, severely malnourished, or disseminated TB infection cases. This is how the TB spot test looks like. It is negative and it is a positive control over here. What are the advantages of IGRA? It requires a single patient visit to conduct the test. What does it mean? TST will require you to give the TST first, and you have to ask the patient to come back after 40 to 72 hours, where in this case, IGRA will require only single patient visit. The results can be available in 24 hours, while in TST, you need to have 40 to 72 hours. Yeah. It does not boost the responses measured by the subsequent test. Means what? If you give TST and if you try to repeat the TST, then sometimes the response is boosted and you may not come to some conclusion. Prior BCG vaccine is very important, which does not affect the IGRA test result, which is a cardinal feature of this IGRA test. And sometimes in some of the patients, few of the patients, second test will be taken as evidence of infection, and few of the patients where TST is positive, but the adherence and acceptance is not there, you can confirm with IGRAs. These are the advantages, but there are certain disadvantages also. Like, it is a very expensive test. It requires a lot of infrastructure. It may not be available in most of the cities. There are a lot of errors in collecting and transferring the samples. One has to have some viable WBCs which are there till it reaches the lab. And even though the test is done, it will not predict whether this patient is going to be active tuberculosis in future. There are certain places where you need to investigate, like children below 5 years, children who are HIV patients, children who are in contact with multi-drug resistant TB patients, children who are having diabetes mellitus, or as well as there are certain who have got additional risk factors like pregnancy, smoking, and alcoholics. But in TST versus IGRA, these are the places where IGRA scores little bit more. When you are investigating a contact, when you are investigating a pregnancy, when you are investigating in healthcare workers, and when you are trying to evaluate serially so that you want to know whether the contact has infected or not. It's very simple. If the age is less than 2 years, TST is preferred. Age is more than 2 years, IGRA is preferred. So this is a very simple thing. If you've got an index case, if you come in contact with it, If you are asymptomatic, then you evaluate for the disease. If there is no evidence of a disease, if you are less than 5 years, you have to definitely, as a universal, you have to go for prophylaxis. If you are in a contact with an index case, if you are asymptomatic, if age is 5 years or more, then you have to diagnose latent tuberculosis infection, and here your IGRA will come to your help. And then if it comes positive, and if you have got a contact with a positive case, then that patient will need prophylaxis. So this is a report of a latest patient which I have done IGRA on one of the patients, 8 years old female child who was Mantu has come ulcerative positive, IGRA has come positive, who has got a contact with TB, but which was not exactly the way it has been mentioned. So what is the latest news? If this TST would have been performing well like IGRAs, then why one would have gone to such a highly costly treatment or costly test? Then what is the difference between TST and IGRA? These antigens, early secretory antigen target 6 and CFP10, they are not there in TST. What is there in TST? We all know RT23 PPD. So if these are available in our TST will be better even if the BCG given patients are investigated by LTBI. That is one. Another, there is something called as QFT GIT plus, which is on the horizon, which has got little more advantage than what is presently available quantiferon gold test. And the TB spot also is under modification, where you will get, because this test needs to be done within 8 hours, but you have got some extension like T cell extend and other T cell select, which are going to be there as an advancement by which this test can be more better handled. So what are the take home messages? Only one take home message. These IGRAs and these TSTs, whatever is the test you are doing, it is to prevent the latent tuberculosis infection, because this latent tuberculosis infection has got tremendous impact on having disease. Like the risk is like progression to disease almost 50% in infants, 25% 1 to 5 years, and 5 to 10 for lifetime. So if you pick up a patient in a right time, then I think you have done the job. Thank you so much. May I stop sharing the slides?
Yes, sir.
Yeah.
Very nice presentation, sir. I would request Devpujari sir to have an expert comments.
So Dr. Patankar, you did a wonderful job.
Thank you, sir.
Honestly.
Thank you, sir.
If suppose cost is not a factor, do you think IGRA would replace TST? What is your comment?
As far as whatever I have gone through the references, it appears to be like that only.
I assume so, because a lot of places now across the world, people are trying to choose this test. But it was a wonderful presentation. You clarified everything. I think I don't have to add much. Great job.
Thank you so much. Thank you so much, sir.
Thank you, sir. I would like to call upon our next speaker, Dr. Amok Shahane. She will be speaking on fitness in adolescence. Amok is a fitness specialist since 7 years in Navi Mumbai. She is a weight trainer. She is consulting pediatrician and adolescent counselor at Navi Mumbai, Sanvi Child Hospital, and she had won 5 medals in 2020 Pediweek Challenge. So, please, Dr. Amok.
Thank you, Sonali ma'am, for this for that kind introduction. First of all, I would like to thank MahaIP for such a wonderful platform to discuss on such important topics in this Tuesday Takes. And respected Gangolia sir, Dr. Amol Pawar sir, hearty greetings to all of you and the esteemed judges. Shall I start with the screen sharing, ma'am?
Yes.
Can you see the slides, ma'am?
No, we are not.
Can Pallavi ma'am share it from there, ma'am?
Pallavi madam?
Yes, ma'am.
Please share.
Okay. Thank you so much, Pallavi ma'am. The topic for today is fitness for teenagers, the real gift of today. As you all know, we just celebrated World Obesity Day on 4th of March this year. And it's very sad to know that almost 340 million people worldwide are obese or either in the overweight category. And this was by a census which was done by WHO in 2016. So actually after the COVID pandemic, where we see so many children walking into our OPDs who have gained enormous amount of weight in the last 2 years. So this seems like a next pandemic on our hands. So as a pediatrician, we need to give a little bit of time to calculate the BMI of every teenager who walks into the OPD to see whether they fall into the overweight or the obese category, and maybe a little bit of counseling to the parents as well as to the teenagers. So next slide, please. So this is a very basic definition of what is health. We've all learned that health is the state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And Dr. John Beard, who is the Director of Aging and the Life Course at WHO, he clearly states that healthy lifestyles from the very beginning of life is the key to a healthy and active old age. So being healthy and fit, it is not just a fad or a trend, but it is a lifestyle. Next slide. Next slide, ma'am. So coming to lifestyle, over here we aren't talking about whether it's a healthy lifestyle or a bad lifestyle. A lifestyle basically comprises 4 things which we do day in and day out. First and foremost being our daily diet, as to what we eat, how much we eat, and what time we eat our food. What are the physical activities throughout the day, and how we can control the stresses in our life, how we can combat adversities and not give in to vices like smoking, drinking, substance abuse, and these days even internet addiction. Next slide. So the crux of today's talk is why should we concentrate on fitness for teens? Because as you know that a teenager, when he puts on too much of weight and he falls into the high BMI category, eventually it leads to NCDs or non-communicable diseases, earlier appearance of these NCDs like early development of diabetes mellitus, elevated blood pressure or hypertension, or even coronary heart diseases for that matter. So bad lifestyle as a teenager will eventually you'll end up with NCDs as an adult. Next slide. So what is fitness? It should be more incorporated into our daily routine as a hobby. It shouldn't be a punishment for what you've eaten, but should be an enjoyable process. So incorporating fitness as a hobby is very essential, and it should be imbibed right from the teenage age. Next slide, ma'am. So what happens with a bad lifestyle? So as you all know, the first thing which usually teenagers can conquer is NCDs. Then they can have, because of a poor diet, they can have depressed immunity. They can go in for addictions because of mental stresses, and because of binge eating and because of preservatives in the food, they can also develop a high risk of cancer. Next slide. So what are these things which we usually do when we are stressed out? As an individual or as a teenager, it's very often seen that to get a pleasure or to get a kick, usually teenagers get succumb to bad habits like eating sugary and salty food, binge eating on junk food. Sometimes even caffeine containing food like cola and drinks are consumed in too much proportion. They can also go in for vices like smoking, tobacco, substance abuse, or sometimes even alcohol consumption. Next. So we need to find some natural ways to increase dopamine in the body, because dopamine, as you all know, it's a neurotransmitter which helps us to stay happy and to have a positive attitude in our life. So there are mainly 3 factors which increase dopamine naturally in our life. That's the first and foremost is sleep. An adequate sleep of at least 8 hours per day, it releases dopamine. Regular exercise increases endorphins or happy hormones. And healthy eating causes a sustained release of dopamine and serotonin, because of which a child is always in a happy and a positive mood. And this is what differentiates it between a pleasure and an addiction. Next slide. So coming to the first factor which you've seen for a natural release of dopamine is good and adequate sleep hygiene. So a child ideally requires at least 8 to 9 hours of sleep, ideally between 10 p.m. and 6 a.m. because this responds to the normal body circadian rhythm, because it increases the sleep induction hormone melatonin, which causes sleep. And we've seen like many children are more exposed to gadgets, especially before sleeping time. And this blue light, it interferes with their sleep induction. So eventually, when the child is sleep deprived, he acquires a sleep debt. And then eventually it goes into a sleep deprivation syndrome, in which the child has some mental changes like poor work for performance, mood swings, and even physical changes like depressed immunity and recurrent infections. Even too much of sleep can cause even obesity and diabetes. Next. So coming to the second factor for a healthy lifestyle is the importance of exercise. So exercise is such a thing that it is really addictive because it is fun. It gives us happiness. It increases confidence in the child. It improves his attention span, his memory, and these are natural stress busters because they release endorphins or happy hormones, which keeps the child active and healthy throughout the day. So the recommended vigorous physical activity of at least 60 to 120 minutes is ideal, at least 5 days a week. It can be moderate or high physical activity like volleyball, cricket, football, or even simpler activities like yoga, aerobics, and Zumba. Next. Along with this, healthy eating habits, that is the rainbow diet, is very important for a healthy lifestyle. That is, we usually go for all green, yellow, orange, and red vegetables and fruits, which are natural and not painted without any artificial preservatives. These are a rich source of micronutrients, antioxidants. They help in improving the immunity and they're definitely needed for brain, skin, hair, and heart health. And these indirectly help us to cope with stress and emotions. Next slide. The food which we need to avoid are definitely crab foods, that is carbonated drinks, refined and ultra refined foods, artificially colored foods, and processed and highly processed foods, especially junk food like pizzas and cream biscuits, because these foods have got very low nutritive value. They have very high fat content, very poor in fiber, and have too many chemicals and toxins which are harmful for the body. Next. Definitely meditation and relaxation techniques need to be incorporated in teenagers, especially around exam times, because that is the time when the child is really anxious, and meditation definitely helps in calming them down and keeping them happy and positive. Last slide. This is the slide which I've introduced for today's times, because social media has played a havoc in teenagers' lives, because nowadays we've seen that almost 52% of time is spent on screens by these teenagers. They have gadgets in front of them all the time. Almost 1/3 of the time they are multitasking. And this is directly associated with very poor grades, poor concentration, and they do not have any time for good hobbies and development of any other physical activity. So once the child is entrapped in this social media addiction, it's very difficult to get them out of it. So the prevention over here is much better than cure. So with this, I would like to sum up this small presentation. I feel that it is a very neglected topic in today's times, but seeing the trend in teenagers and even younger children for that matter, it's high time that we take it seriously, and everybody needs to act, as it is a slogan this year for the World Obesity Day. So I really feel that all of us as pediatricians should take a pledge to keep fitness as a very important part of a child's life and counsel parents and teenagers accordingly in a day-to-day OPD. Thank you very much.
So,
Thank you, Dr. Amok. I would like to request Dev Pujari sir for his expert comments.
So, Dr. Amok, nice
Yes, sir.
presentation.
Thank you, sir.
Are the slides made by you?
Yes, sir.
Great. When I take some lectures on art of presentation, they have been very well done.
Thank you, sir.
Secondly, when you advise diet for adolescent, what would be your recommendation of proteins in his diet? Because you'll see boys and girls going to gym and increase their protein intake to more than 30, 40, or they go into even keto diet. Do you recommend this, and what is your recommendation for this kind of thing? But this is what most adolescents will be looking for. And what kind of proteins would be your advice for such?
We definitely would not advise a keto diet, because even if they're going to the gym or having any other vigorous physical activity, they need to take at least 1 gram of protein per kg per day, which is the ideal recommendation. So we definitely advise them to have a high protein diet, because right now they're in that phase where they need a lot of protein in their diet along with carbohydrates. So we ask them to have more of egg proteins, more of soya bean, a lot of dry fruits, and try to avoid junking. But definitely never go on a crash diet or a keto diet, but a good protein diet with a lot of water intake also.
So if I have to make a flat statement that there's no replacement of white of an egg for protein as compared to some of the costless protein, which could, 7 days requirement for a 50 kg child going to an active gym would be about something like 15 to 20,000 rupees. What would be your advice? That you stop everything and take 8 eggs or 10 eggs per day and just take white. Do you think this is a correct statement?
No, that would be a little difficult to tell them. So it depends on the activities also, because going on a complete egg diet, especially with vegetarians, is very difficult. But at least 0.5 to 1 gram per kg, we try to advise them to have that much protein, depending on what activity they're doing.
So suppose he's spending 40% of his calories in exercise. That's what some of the athletes recommend. And why I'm asking this? Because now you see youngsters who really want to build their body. They want to go to athletes, and the recommendation is spend 40% of your diet in the calories during exercise. The new recommendations are to take egg white. So can you make a statement, because the amount spent on getting the ready-made proteins is very high. So what is your take on this?
So naturally derived protein is definitely better than synthetic proteins. And younger children, they should go for a natural protein source, not for expensive protein supplements.
And if he says he is Jain and a pure veg?
So then they can go for vegetable sources like soya bean, then a lot of dry fruits, sprouts. These are very good sources of protein too.
Can you ever come to reference protein? Because the biological value of vegetable proteins is just about 35 to 40%. However best you might do.
That would be a little difficult. They don't have eggs, little difficult.
That would be almost impossible. And but good presentation. Thank you. Yeah.
Thank you, sir.
Thank you, sir. Now, moving on to our last speaker of this session. I would like to call Dr. Sachin Patil. He's from Yavatmal. He would be talking on approach to crying infant. Dr. Sachin is a neonatologist and pediatric intensivist. He is director of Patil Kids Criticare, Yavatmal, and he's trainer for EPIC, NRP, BLS, picnic modules of IAP. So over to you, Dr. Sachin.
Good evening, everyone. I wish to am I audible, ma'am?
Yes, sir.
Pallavi, ma'am, you have to share my PPT. First of all, I wish to extend my deepest respect and appreciation to all the dignitaries of MahaAP for giving this opportunity. And special thanks to respected Dr. Devpujari sir for guiding me for this presentation. Without wasting much time, I will go ahead with today's topic. Today, I am discussing regarding the approach to crying infant less than 3 months age. Next slide. We all know that crying is the most common complaint for which child is brought to pediatrician. We have to differentiate when the cry is abnormal and needs evaluation. And each case should be looked as a clinical challenge. Fear of missing the diagnosis may result in unnecessary and invasive tests, which may be pay extra cost on the parents. Hence, the role of pediatrician is very important, especially to avoid and missing a serious or life-threatening event. Next one. We all know that complaint of crying is so non-specific that there is a multiple DDs and all DDs are so extensive. Hence, we need a detailed clinical examination, and on the top of that, your clinical experience will help to evaluate the baby and come to the shorted diagnosis. Next one. In this, we need a systematic approach. We have to examine the patient from head to toe. During general examination, we have to see the temperature, pulse, respiratory rate, and hydration status. We have to examine the head also, whether anterior frontally is boggy or depressed. Are there any prominent veins over the scalp? Is there any suture separation? We need to do some otoscopy also to evaluate is there evidence of any AOM or middle ear infection or discharge or any foreign body. We have to see throat, especially for vesicles. Then pulling of secretion is there, like is there any parapharyngeal abscess or what. We have to see eyes to see any injury or any foreign body. Next. During neck examination, we have to see whether there is a mass or lymph node. On mouth examination, we need to see whether there is a aphthous ulcer or oral candidiasis or stomatitis. During respiratory system examination, we have to see whether there is a tachypnea, are there crepes, any bronchial breathing, or any evidence of foreign body. On per abdominal examination, we need to see there is a lump or mass like intussusception, which is very common. And if required, always perform per rectal examination. And the most important is, don't forget to undress the child, because we have to evaluate impacting inguinal hernia, torsion testis can be missed there. On musculoskeletal examination, is there any fracture, any septic arthritis, or any scurvy-like pictures are there. During CNS examination, we have to see the behavior of the baby. We have to examine for the toxicity, whether baby is toxic or normal. Are there any convulsions or focal neurodeficits are there? And genitourinary system examination, whether there is any periurethral rash or abscess. Next one. Is we have some mnemonic like it cries. It means I stand for infections like herpes, stomatitis, UTI, meningitis, osteomyelitis. T stand for trauma, whether it is accidental or non-accidental, or testicular torsion. C stand for cardiac like supraventricular tachycardia or congestive cardiac failure. R stand for reflux or any reaction to medication. I stand for immunization, especially post-DPT injections. E stand for eye examination like corneal abrasion or foreign body, and S stand for surgical like volvulus or intussusception. Next one. Hence, if there is any baby which is less than 3 months, then we have to first see danger signs like temperature. Is there hypothermia or hyperthermia? See a SpO2. If it is less than 90%, definitely it's a danger. Is there any evidence of respiratory distress? Vomiting is there, blood in the stool is there, or any swelling, any bruise or abnormal movements? Are the anterior frontal are tense? These all are danger signs. If we see this, always admit the patient. But if these danger signs are not there, then if it's the first episode of crying only, then ask some questions like feeding, how's the feeding pattern, top feed baby is there, cow's milk is going on, or bottle feed is there, are there any drugs or any cold in the family? To roll the commonest cause is nasal black. Vaccination, like as I mentioned earlier, DPT vaccination. Is the cries inconsolable? Then look for some features like poor weight gain is there, failure to thrive is there, how's the poor activity is there, abnormal posturing, any focal neurodeficit. Then as I explained earlier, detailed examination of head to toe is required. Hence, if some positive finding is there, then we have to observe or admit. If such episodes are recurrent, but in between recurrent episodes, baby is fine, then we just need assurance. Next one. These are some red flag signs like evidence of respiratory distress, bruise and abrasions, extreme irritability, fever and inconsolable cry, fever especially in less than 2 months, or tense anterior frontal. These are the red flag signs for any crying infant. Next one. Is the take home message is detailed history and detailed clinical examination are the must. No universally recommended lab test or imaging studies, only individualized decisions. Colic and unexplained crying are the still most common and underlying serious pathology should not be missed. Next one. If we have to discharge such baby, then baby should be well appearing, well consoled, and there should be assessed for immediate follow-up care if need within 24 hours, and there should not be any social concerns. Then we can discharge the baby from the emergency department. Thank you. Thank you for patience listening.
Excellent, Dr. Sachin. I would like to invite Dr. Devpujari sir for expert comments.
So, Dr. Sachin, you have done a complete coverage of excessively crying infant. Now, if a baby like this comes to you, how often do you give antispasmodic drops? Be very honest.
No, sir, very less.
Really, I'm so happy.
Rather than antispasmodic, we will use drugs for sleep, like maybe hydroxyzine.
So, do you give drugs for sleep?
No, sir, for as a sedation, if required, if all the serious illnesses are ruled out, then only.
No, my question is, if a baby comes to you crying, baby otherwise is apparently normal, you've done all your exhaustive examination and you have completed the whole list. Apparently, it seems like this could be one of the normal excessive cries. But to satisfy parents, what do you do?
Sir, counseling. If there is no need of any medication, we have to counsel only.
So most often of all your babies, none of them get any medicines?
No, sir. Counseling and rest for at least 20-30 minutes in our OPD. That is my best advice.
Right. I'm extremely happy. Believe me, in my life, I've never ever used any of these drugs. And I don't think they are needed. There's no need for any of the antispasmodic drugs or any of these drugs for so-called gas. And though all said, a lot of these drugs are used. But good, you're not doing it. That's one. Second, now, if a baby comes to you who is crying like this, tell me some instances where you were shocked. You saw everything was fine. Okay. And, suddenly next day you find, oh, I missed this. Do you have a list like this? I should have picked this up earlier. Any of these things you have in mind for the last so many years? You got my question. Like you saw it on Thursday and you're happy. You're assured, like we all are assured parents, we have assured them. And next day, something else comes out. Any list of such conditions?
No, sir. Till now.
You have been very fortunate. I'm sure as a clinician, you must have had something which you felt you would have diagnosed earlier. Not a single cause?
No, sir.
Okay, good. That we are a very good clinician then. Okay, now tell me one thing. Amongst the so-called drugs for pain, you don't use antispasmodics. You don't use drugs which are so-called, for so-called gas and things like this. What would you do? Would you give paracetamol, ibugesic?
Paracetamol drop if required.
Right. So SOS you could give paracetamol. Now, what could be your standing instructions on your paper that you see a child like this? And on the OPD paper, what would you say as to when they should come to you?
Sir, if there's such a recurrent episode, if within 24 hours, baby is not accepting feeds and some danger sign like excessive lethargy or any convulsion.
So say, let's imagine you've seen 100 such patients excessively crying. What percent, by and large, you would investigate and what percent you would assure them everything is fine? Rough this thing, of the 100 patients that you saw for excessive crying, as someone in practice, by and large,
sir, approximately 5 to 10% who have to need investigation. We need investigation.
Perfect. Thank you very much. That was a great presentation and excellent discussion. Thank you.
Thank you, sir.
Thank you, sir. Someone, Dr. Chitra has commented in chat box that AO is a condition where the patient comes again in OPD with unconsoled cry. Sir had asked the question to Dr. Sachin. Okay, thank you, sir. Thank you very much. Thank you all the speakers. Now I would request our WC chairperson, Dr. Renu ma'am, to have an vote of thanks.
Yeah, thank you, Sonali, for letting me give vote of thanks. Actually, it was a very great evening with a super fast train that has stopped now and come to a final destination. So I would like to thank on behalf of Women's Committee Maharashtra IAP to take this opportunity to thank our own President of Maharashtra IAP, Dr. Gangolia sir, and Secretary General Dr. Amol Pawar for giving us this platform for presenting the second episode of Tuesday Techs. Our esteemed judges of today, Dr. Dev Pujari sir and Dr. Bhamri sir, I express my heartfelt gratitude to you for sparing your valuable time to guide our speakers and also helping attitude of yours to always ready to help. Even yesterday, Bhamri sir was there in rehearsal all the while for 1.5 hours. So thank you so much to both of you, sir. And also our moderators today, Dr. Sonali Shirbhate and Dr. Sunita Ingle ma'am, they have done the planning as well as the execution of the program very excellently. So I thank both of them. The energetic and enthusiastic speakers of today, I thank each one of them for their contribution in this academic feast. I would thank Dr. Amol Murkute, Dr. Anurag Pangrikar, Dr. Bhavesh Shah, Dr. Abasaheb Patankar, Dr. Amok Shahane, and Dr. Sachin Patil. The respected audience, I am very much thankful that you are present today till the end for our speakers. You are encouraging them and also listening to them very attentively. I thank each one of you. I see many seniors, Dr. Khadke sir, Dr. Chitra Kulkarni ma'am, and Dr. Reena ma'am, Dr. Bond sir, etc. So I thank each one of them, also the OBEBs who have joined here today. And last but not the least, the digital partner and the digital visa, Dr. Vishal Raut and Mrs. Pallavi Dharmadikari, without whom today's PPTs couldn't be shared. And our speakers would also like to say thank you on behalf of them. I thank both the digital partners. And also a gentle reminder that the next episode is on 19th April at the same time, 9 p.m. So I request all the audience to be there to encourage our new speakers, new judges, and new moderators. Thank you so much, each one of us. Take care. Good night.